form and start your systems. You're going to be dealing a lot with maintenance of fluid in the body and how that impacts each of the body systems that you're going to cover. I don't see Kim Morey. When Kim, is she here? When Kim comes in, I'm going to stop and we're just all going to look at her and say, "Good morning, Kim." Okay?
You want to say quiet?
Yeah.
Okay.
All right, so.
What about?
So, this is not an all-inclusive lecture. This is sort of an introduction to body fluids. You're going to get this topic in various forms as you get through the body systems, because renal will go into the renal aspects of fluid maintenance. Cardiology will do that. Pulmonology will talk about pulmonary edema, and so you're going to get it from a lot of different directions, but this is sort of the overview, okay? So the first slide here goes into exactly how much fluid we're talking about. If you weigh 200 pounds, 120 of your pounds is water. That's pretty impressive. And then you have to break down the content of water into different compartments. And while the slide here says that there are 2 compartments, there are actually 3 that are on this slide. First of all, 2/3 of that weight is intracellular. Within the cells, there it is. The other 1/3, though, is extracellular. So if you weigh 200 pounds, 20%, that's 40 pounds is extracellular. Good morning.
Thank you.
Look how red. Oh, that was good. That was good. All right. So 40 pounds of your 200 pounds is extracellular. 40 pounds. And of that 40 pounds, only 10 pounds is in the vessels. 30 pounds of the extracellular is out in the connective tissues, outside of the vasculature, within the subcutaneous tissue, within the muscle fibers, all in the extracellular space. Now, as that last bullet point says here, water may be lost from either compartment. And by the 2 compartments there, they're talking about intravascular or extracellular. But then water can move between those 3 compartments. You can have water moving in and out of the cells just as easily as it moves in and out of the extra and intravascular spaces. How you keep track of the status of fluid basically is by weighing the person. Weighing the person, if you're in the hospital, you weigh them every day. Keeping in mind that a gallon of water is over 8 pounds. So if you get a person with congestive heart failure that you saw last month and is in this month for a recheck, and they weigh 32 more pounds than they did last month, they can't breathe, you have to consider that they have 4 gallons of extra fluid on board. When you put it in that context, that's a lot of fluid. All right. Taking a careful history about how much they take in, what they take in, and the principle you need to appreciate from the start here is that water follows sodium. So if you have a high sodium diet, you're likely to retain fluid. A lot of people, especially those with congestive heart failure or hypertension, you want to put them on a low sodium diet so they don't retain the fluids as much. If you want to appreciate how much fluid you can retain even with your normal kidney function, eat a bag of Ruffles tonight, a family-sized bag of Ruffles, and see if you can get your ring off tomorrow morning. You'll be puffed up like the marshmallow guy, okay? Physical exam is the next thing you need to pay attention to. Physical exam in terms of, well, the next slide will give you the physical exam issues we need to address. So save that point. Measuring electrolytes, particularly of the serum, particularly sodium that you'll see in just a minute, is a very important component of keeping up with fluids. Now, when you get into specializations like nephrology, they spend a lot of time measuring the concentration of electrolytes in urine. For general practice, you're not going to do that. You're going to focus on what the serum electrolyte concentration is. Now, when you order a certain lab test, you automatically get the serum osmolality, which will give you, is one of the determinants of how fluid moves. We'll see that later on. And finally, the urine-specific gravity is another measure of your hydration status. Now let's stop for just a second and talk about the difference between osmolality and specific gravity. A lot of people think they're the same. They're not. Osmolality is the ability of, well, is basically the measure of the concentration of a solute in a solution. So if you have one sodium ion, and it's the number. It's the number, not the weight. It's the number. So one sodium ion in albumin that weighs 64,000 Daltons is the same when you're talking about osmolality. Those two attract fluid the same. It's the number versus specific gravity, which is the weight. So if you have urine that's full of sodium ions, the osmolality will be high, the weight will be low. If you have urine that's full of albumin, the osmolality will be the same as that of sodium, but the specific gravity will be much higher because albumin is heavier. So you can boil it down to osmolality is the number, specific gravity is the number and the weight of particles. Okay. All right, assessing fluid status. One of the easiest things to do is systolic blood pressure. You know, in you, and in most folks, what you're looking for maintaining is a systolic blood pressure of at least 90 millimeters of mercury. Now, and an 88-year-old little old lady, sometimes their normal systolic blood pressure is at 90. But in most folks, they have most adults, they have a pressure of at least 90 systolic. If you come in, I mentioned this yesterday, if you come in and because you've been bleeding out or you've been taking an opioid, you're overdosed on opioids and your blood pressure is down, but let's say your blood pressure is 75. If your blood pressure is 75, remember blood pressure is related to cardiac output. Cardiac output, the force of cardiac output is blood pressure. perfusion of the tissues is based on blood pressure, not your pulse. It's based on pressure. Perfusion of oxygenation of tissues is based on pressure. So if for whatever reason your blood pressure is too low, one of the quickest things to do to get it up is to give you 1 or 2 liters of fluid. To start an IV, slam a liter of fluids in you. If you have a closed vascular system, think of it as a plumbing system, and it's closed, there are no leaks, you put another liter of fluids in there, what are you going to do? You're going to raise the pressure of the intravascular system. So whenever you're faced with the pressure is too low, to get it elevated, to raise it, what's the easiest solution? 1 to 2 liters of fluid. That's the easiest thing. Now, in adults, you want to at least have a systolic of 90. I had a patient one time that came into the emergency room. He was having a full-blown myocardial infarction. It was a term you may hear. Is if this is the P wave, there's the sort of the normal. Let's not make that quite so big. Normal PQRST that you're going to learn about in physiology. When you have ischemia related to the heart, the ST segment will elevate. So this is an ominous sign, right? This is something that tells you something bad's going on. If you see that ST elevation, well, and this guy that came into the ER, his ST elevation looked like that. That's called tombstoning, because it looked like a tombstone, right? That's some bad stuff going on with you right there. So one of the things that you do in a person that's having an MI is you give them morphine and nitroglycerin. They both decrease the work of the heart, and nitroglycerin dilates coronary arteries. The problem with giving those 2 drugs is that they lower blood pressure. He was my size, and when he came in, his blood pressure was about 85 systolic. You need to appreciate that if you gave him morphine and nitroglycerin and dropped his blood pressure, you're going to make his ischemia worse, because pressure determines perfusion. So his coronary arteries aren't going to perfuse as well. So the quick solution to him is give him a couple of liters of fluid, raise his blood pressure, and then you can give him the morphine and nitroglycerin. Follow me? You're going to be faced with that same decision. You need to quickly come to that conclusion. Give him some fluids, raise his blood pressure. Then we can treat his condition. Now, in little kids, like a 4-year-old, a 4-year-old's normal systolic blood pressure is not 90. Okay? You will learn later on there is a formula for determining blood pressure in children. I'll just give you the example. Let's say the 4-year-old, for a 4-year-old, it's, and you don't need to write this down, 70 plus 2 times the age. So 4-year-olds, is 8 plus 70. His systolic blood pressure should be 78. You follow me there? 78. If this kid has not been eating, drinking, if he's been having diarrhea, he's been throwing up, he's been running a fever for 4 days, you need to determine whether or not this kid is dehydrated, take a systolic blood pressure. If his systolic pressure is not at least 78, that kid is in shock. And you have to address it by giving fluids. You follow me on this? All right. Systolic blood pressure, critically important. The other is orthostatic hypotension. And that means if you're lying down and you stand up, your mechanisms, the physiologic mechanisms in your body react instantly to make sure that the positional change doesn't, because of gravity, drop your blood pressure. The blood doesn't pool down in your feet and you pass out. People who are dehydrated, though, they lose that mechanism because they don't have enough fluid to sustain the position difference. If you get lightheaded, if you drop your blood pressure from supine to standing, that's called orthostatic hypotension. It happens a lot in the geriatric folks who are sitting down, they stand up too fast. There's a thing called a tilt test, T-I-L-T, tilt test, that you'll learn. And basically what you do is you know, if you came in and one of your complaints was dizziness, dizziness can come from several reasons. It can come from neurological causes, it can come from you're dehydrated, it can come from endocrine, all sorts of things. One of the things you do to exclude the cardiac end of it is to lie you down, take your blood pressure while you're lying there for 5 minutes, then we'll take your blood pressure, okay? Then I'm going to sit you up and take your blood pressure again, immediately. And then I'm going to stand you up and take your blood pressure again. So you go from lying, supine, sitting, standing, rapidly, and you take your blood pressure 3 different places. If you get a 15, some people say 10 to 15 millimeter mercury drop in blood pressure, that's orthostatic hypotension. It tells you that there's probably a fluid issue going on. Okay? Orthostatic tilt test. Don't ever forget that. By the way, everything I say this morning, you have to remember for the rest of your life. Everything Professor Torres says from 10 to 12, you have to remember for the rest of your life. This is your business now. Okay? Urine output. The best way to determine your volume status is how much you pee. Normally you're going to pee 1 to 2 liters of fluid a day, or urine a day, depending on how much you take in. If you're not taking in, or if you're dehydrated or whatever, you're not going to pee as much. If I have a person in the hospital who is not peeing, then it's because I'm not giving them enough fluid or their renal function is shot. If a person does not pee, you're headed, or they're headed, for bad stuff within 24 or 48 hours. You have to, so if a person is in the ICU in septic shock, they have an overwhelming infection. Fluids alone is not enough to keep their blood pressure up. We have to use pressors. We've got a dopamine drip running in this arm. We've got a dobutamine drip, which is a similar sympathomimetic, running in this arm. What are these? Dopamine, dobutamine, epinephrine, norepinephrine. You've had these in anatomy. What are they going to do? They're going to increase pressure. They're fight or flight. I'm trying to increase your pressure, but your sepsis is overwhelming. Your physiology, one of the ways I measure whether or not the pressure is good enough is not only by blood pressure, but by your urine output. If you're not producing 10 milliliters of urine an hour, you're not going to make it. Okay. So urine output. Put a Foley in them. Foley catheter goes in the urethra, into the bladder. and you can measure the urine output in milliliters.
You said you're supposed to produce 1 to 2 liters a day
Yeah.
here.
Uh-huh. Skin turgor, we talked about in the first day of anatomy. If I pull up on the skin like that, it goes back down, right? That means I'm hydrated. A person who is not hydrated, when you pull their skin up and let it go, a person who's dehydrated, I should say, when you pull the skin up and let it go, it stays up. That's called skin turgor. That is called tenting. You measure skin turgor. Skin turgor is not useful in little kids and geriatrics. In your ages, everybody else, you want to assess skin turgor. Capillary refill. If I take, I think we talked about capillary refill as well. If I take, did we talk about capillary refill? We did? Yeah. If you press on the nail bed and you blanch it and you let go, it should re-pink back up within 2 seconds. A person who doesn't have enough fluid is not going to have the perfusion necessary to pink it back up. So a delayed capillary refill. Normally it should be less than 2 seconds. Mucous membranes are going to be dry if you're dehydrated. So always look in the mouth and look in the conjunctiva. Conjunctiva is moist. Mucous membranes are moist. When you're dealing with little babies, if they're crying but not forming any tears, that also tells you they're dehydrated. If a baby can form tears, they're not dehydrated. Serum sodium, we talked about just a minute ago. I'm going to talk more about it as we move along here. And recording INOs. INOs means ins and outs. When you're a hospital patient and you want to keep track of a patient's fluid status, which you will be doing on a daily basis when you get to the clinic or get to the hospital situation, you write an order for INOs. The nurses will keep track of every milliliter of fluid that goes in that person. Through an IV, through the orange juice they drink in the morning, they'll quantify, they'll tell you exactly, and outs. They'll measure the exact volume of urine they produce over a 24-hour period. And usually, if you're going to record, if you're going to write an order for INOs, you also want to make sure that they get daily weights. A lot of times in hospitals, they don't get daily weights unless you specify it. So if you're dealing with somebody with diabetes, congestive heart failure, malignant hypertension, an endocrine problem like thyroid or Cushing's disease, anything like that, you'll want to do INOs and daily weights.
You didn't mention the breast sounds.
Breath sounds. You should have breath sounds. One of the, so if I put a stethoscope on your chest back here, you should just hear air move. Nice air flow, right? In people who have congestive heart failure, volume overload for whatever reason, they have fluid present in the lungs. So when they take breath sounds, when they breathe, especially the lung bases, because that's where fluid is most of the time going to go, right? Inside the lung, it's going to go to gravity. You'll hear what are called rales, R-A-L-E-S. A lot of people describe them as crackles. And what crackles sounds like is when they breathe in or breathe out, mostly breathe in, if you take your hair, you know, you gotta get longer hair. If you take your hair and do like that. Just twirl it by your ear. If you take a deep breath in, that's what a crackle sounds like. That is suggestive, it's pathognomonic of fluid within the lungs, not around the lungs, like a diffusion in the lungs. Okay? All right.
Dr. McNeil.
Yes, ma'am.
Yesterday we talked a little bit about orthostatic hypotension, and we got slightly different numbers. I was wondering, would you go with 10 to 15?
This is a principle of medicine right here. You need to understand that there are 15,000 different ways to do things, and there are 15,000 different normals. So if somebody said that a 5 millimeter change was a positive tilt test, or a 20 millimeter, you know, that range, okay? What did they say?
20.
20, yeah. I always learn 10, so it doesn't matter. It's within an acceptable, if you know, it's like if you call the insurance company and ask them a question, you talk to 10 different people, you're gonna get 10 different answers. Okay? By the way, the jackass I spoke to at AT&T U-verse on Friday night when the internet at home went down along with the TV, and said they're gonna mail out a little gateway tower that you plug the crap into, that would fix the problem, and we got it yesterday, we plugged it in, and it didn't fix the problem. It was a jackass. Okay. All right, so what drives, we were talking about the fluid moving between intra and extravascular spaces. What drives that? There are four forces. They're called the Starling laws, and there's the formula for it. I added the formula at the bottom. Your slide may be a little different than what mine is. I made a couple of tweaks last night. But I put the formula in there in case you're one of those kind of people that gets off on formulas. There's basically hydrostatic forces that drive fluid. In other words, pressure. Pressure drives fluid out of the vasculature. Pressure drives fluid from the extravascular space back into the vasculature. So there's a pressure gradient on either side of the vessel. There's also the osmotic forces. In other words, the concentration of, let's say, the solute inside the vessel versus the solute outside the vessel is going to drive forces in and out. So we'll talk about each of these later in just a minute here. So those are really the two forces, each coming from either the intravascular space or the extravascular space that moves fluid between these two compartments. All right. Here's a definition of osmolarity. So in this slide here, when we talk about the osmotic forces here, what determines the osmotic forces, especially intravascular? Oops, wrong way. And here it is. Your normal measurement of the osmolality of your blood, what's circulating in you, is around 300 milliosmoles per kilogram of body weight. The formula that you see here says that 2 times the value of sodium. Remember, osmolarity is the number of particles in the blood. The concentration of sodium in your blood is about 140 milligrams per deciliter. 140. So 2 times 140 is 280. Plus glucose. Your normal glucose, we'll say, is is 100. Divide that by 18, and then you take the blood urea nitrogen, which is another substance you'll measure in your blood, and you divide that by 2.8. So in a normal person, in you, we've got 280 plus 5 plus your normal BUN, which is about 20. So we'll say that's another 8. That equals that. Keeping in mind that the greatest component of serum of your blood's osmolality is sodium, by far. Remember that sentence. The major constituent influencing extracellular, that says extracellular, should be intracellular osmotic pressure is sodium. By this formula here. I want you to keep in mind, though, that when they say extracellular here, that also holds true. This is not the formula for extracellular sodium. This is the formula for intracellular, but sodium is concentrated in the extracellular space as well. Okay? More so outside the vasculature within cells. Okay, you have a high sodium concentration in cells. All right. Any questions about this? If you just change this right here to intracellular, that will serve us well today. Okay? Yes, ma'am.
The slide says osmolarity, so is that different from osmolality?
I don't even want to get into the difference between osmolality and osmolarity. The difference is not enough for us to deal with, okay? I don't even remember it myself. I don't care.
I'm saying
This is what you
which one?
measure in the clinical setting, osmolality. Okay? All right. So disturbances of fluid balance. If you don't have enough, that's called hypovolemia. I said yesterday that when you're talking about pulseless electrical activity, what's the number one cause of PEA? Hypovolemia. You're bleeding out. Your blood pressure is going to be low. Your perfusion is low. Therefore, your capillary refill is going to be increased. Your urine output is going to be decreased. Your systolic blood pressure is going to be decreased. You're going to have orthostatic hypotension. You see how all this fits? It all makes sense. Everything makes sense. To fix it, you give fluid. How much fluid do you give? Huh? 1 to 2 liters. By the way, how much fluid do you need a day? How much fluid, because you burn fluid, right? You got all these chemical things going on in your body, you burn fluid. How much fluid do you, if I put you in a hospital and you couldn't take anything by mouth, if I didn't give you any fluids, you'd look like a raisin the next day. How much fluid do you need? Do you think you need the same amount of fluid as Brock?
No.
Brock could eat you. Okay? By the way, the white coats, yours is causing a real problem. They've taken a parachute. So they don't make 9X little sport coat things. So, anyway, what were we talking about? Okay, yeah. So if I put you in a hospital and you in a hospital, I'm clearly not going to run an IV at the same amount of fluid, right? There's a formula for that. There's a formula for everything. Your basal fluid requirement a day is based on the rule of tens. All right, so here's something that I want you to understand right now. If I say you weigh 90 pounds, how many kilograms is that? Tell me, right now, right now. You should have answered, right now.
200.
200 kilograms. Unless you weigh 440 pounds, that's the wrong answer.
Divided by 2.
45.
There we go.
Okay, here's the thing, for the rest of your life, they're 2.2 pounds in a kilogram. So if I say you weigh 90 pounds, divide it by half, and add a little more with a 0.2. That'll get you in the ballpark. So half of 45 plus a little bit more, 48 kilograms. You weigh 48 kilograms. Remember that for the rest of your life. Because somebody's going to say, Blair weighs 120 pounds, how many kilograms is that? Quick, tell me now. 65. That's it. You have learned so much right now. Okay. All right, so the amount of fluid you require is based on kilograms. That's why I want you to know that. Divide by half, divide pounds by half, add a little more. All right. It's called the rule of tens. For the first 10 kilograms you weigh, you multiply times 100 cc's. So where we got here, Blair weighs 65 kilograms. So the first 10, 1 to 10 times 100, so that is 1,000, right? 1,000. If Blair only weighed 5 kilograms, you would say 5 times 100 is 500 cc's. That's how much she needs, period. But she weighs 65. So the first 10 of her kilograms, we're going to multiply it times 100 to give us 1,000. The next 10, from 11 to 20, we're going to multiply it times 50. So there's another 10 kilograms. So there's 500. So what we're left with here is we started with 65, we took off 10, 55, took off nothing, 45 kilograms. We're left with 45 kilograms, right? For the remaining number of kilograms, you multiply it times 20. So 45 times 20 is what, 900? Add it up, that's 2,400 cc's of fluid a day. In a 24-hour period, that's how much fluid she needs to do to get for maintenance. If you throw in things like diabetes, a fever, you have to make adjustments to that. You have to increase it, but that's her basal body fluid requirement.
Can we do one more example?
Uh-huh. Let's do Macy.
Oh, Lord.
All right, so let's do,
95 pounds. And I was born.
let's say we have a child that weighs 16 kilograms, okay? Or let's say he weighs 22 kilograms, 22 kilograms. For the first 10, it's times 100, so that's 1,000. The second 10 is times 50, 500. We have 2 kilograms left. 2 times 20 is 40. His basal fluid requirement in a 24-hour period is 1,540. Okay, you have let's say a 1-year-old that only weighs 12 pounds. 12 pounds is what? How many kilograms is 12 pounds? 7 kilograms, roughly, 7 kilograms. 7 times 100, because it doesn't even get the first 10, right? That child needs 700 cc's of fluid in a 24-hour period. That's how you determine that.
Is this like to survive or
That's basal.
just, oh, okay, gotcha.
That's basal. That's to keep your kidneys working. Okay?
For the, when we calculated fluid replacement for the burns patient
Yeah,
in 24 hours, do you just give that first in the first 24 hours and continue with this?
no, it's, you use that formula, disregard this.
Okay.
Now, once you get them stabilized, you're out of the woods in terms of the burn. If they're still in the hospital, you're going to use this, because you don't want to drown them. You know, the other thing is that, appreciate this, is that this is just your basal requirement for water. You have a basal requirement for sodium, for potassium, for calcium, for chloride, for glucose. So we'll get into all that later on. This is just water, biologic water. Okay, too much hypervolemia. Okay, but where is it too much? Is it within the vasculature, or is it within the extravascular compartment? Okay, intravascular, it says it's venous pooling. Appreciate though that if the blood pools in dependent venous compartments, it's going to put back pressure on the whole venous system. You're going to increase your hydrostatic pressure, so fluid is going to come out of the venous system into the extravascular space. That's edema. All right? You met with your parole officer at this point? Okay. If the amount of fluid that you have is just right, you know, the baby bear, or no, not the baby bear, which one was, no, well, which one was just right? The mama?
No, the baby.
The baby was just right?
Yeah.
The dad was too hot, the mom was too
Yeah.
cold, the baby was just right. That's called euvolemia. Euvolemia. It doesn't, like it says here, it doesn't mean that you're not going to have fluid problems. It just means that in terms of the distribution of fluids, you're okay. And I bring this up because if a patient is euvolemic, if they don't tent, if they don't tilt, if they're moist mucous membranes, then you don't need to address the fluid problem right then. That's not your main concern. Okay? In pediatric life support, you're going to learn that there are different types of shock. There's cold shock. Now, a shock would be like if she comes in and her systolic pressure is below what it's calculated to be. You know, the 70 plus 2 times the 8. If your systolic, if it should be 78 and your systolic pressure was 55, you are in a bad degree of shock. And there are different reasons for shock you'll get to later on. But there are 3 different types of shock in children. Cold shock is one, and that's where the peripheral vasculature has clamped down. It's constricted down to try to shunt blood to the core, so your fingers, your arms are cold. You feel the pulse out here. There's no pulse. That's called cold shock. You treat it one way. The other is warm shock, where it's hot, like she has a fever from sepsis, and it's hot. She's hot. She's volume expanded out here. And there's another one called normotensive shock. Their blood pressure is normal, yet this kid is in shock. So I say that just because euvolemia is a real thing. You can have disturbances of fluid distribution, but your overall fluid status is fine. All right. dynamics of overall fluid balance. In heart failure here, congestive heart failure we'll cover later on when we deal with right and left heart failure. But essentially, you have a decrease in the amount of blood flowing through the kidneys. Decrease your renal blood flow. Activation of the renin-angiotensin system. If you have a drop in blood pressure, you're going to secrete renin. Renin produces essentially angiotensin 1. Angiotensin 1 is converted to 2 by angiotensin converting enzyme. Angiotensin 2 acts on the adrenal medulla to secrete aldosterone. Aldosterone causes a reabsorption of sodium by the kidneys. Where sodium goes, water goes. The increase in water will cause an elevation in your blood pressure, which shuts off renin production. This system here, you might as well commit it to memory because you're going to use it each and every day of your life for the rest of your life. By the way, if you have an increase of sodium reabsorption, you sacrifice potassium. You sacrifice, so you're going to pee out potassium and keep sodium. Aston, you look like you've got gas. What's the matter?
She does.
You okay?
Yeah.
All right.
Things over here.
Any questions about this? All right. This, the reason this is so important is because not only does it impact cardiology, pulmonology, nephrology, endocrinology, a lot of the antihypertensives that you're going to learn about in pharm relate to this system. There are inhibitors. I've already talked about one, angiotensin converting enzyme inhibitors, ACE inhibitors, like lisinopril is an example. That blocks that. That blocks your ability to reabsorb sodium. That decreases intravascular volume, which would do what to pressure? Lower pressure. Hydrostatic pressure. See, this crap all makes sense. It's that easy. It's just a little loop. Everything in this business is a little loop. All right. I'm not exactly sure where we are on this slide here, but, oh, okay, we're all the way down here. Okay. So if you activate this system and you start retaining fluid, but your decreased pressure is not due to volume loss, it's due to cardiac output and pressure decreases. Your kidneys say, your pressure's low, we gotta get it up. You start retaining fluid, now you got edema. That increase in hydrostatic pressure within the vessels leaches out into the extravascular space, now you got edema. Oh, there it is right there. This thing can also happen, edema can also happen, if you have renal failure. Renal failure, well, let me back up. Up here, malnutrition. We'll talk about this later on, but malnutrition, one of the principal things that your liver makes is a protein called albumin. Albumin is the most prevalent protein in your blood. If you decrease the amount of albumin, understand that's going to have an impact on osmolality. So it's going to change the direction of osmotic flow. If the concentration of albumin is low intravascular, where's fluid going to go in terms of osmosis? Fluid travels to the place with the highest concentration of particles, which is going to be extravascular, right? So fluid's gonna come out of the vascular space into the extravascular space, and you're gonna swell up. If you don't have enough albumin, fluid will leave the vessels because of osmotic pressure. Okay? Just to make sure everybody's on the same page here. If you have two that hung me up. I thought that was a chart. If you have if you have a semi-permeable membrane, which is what the endothelium is of the vessels, and you have a lot of stuff over here and not so much over here, the direction of flow because of osmosis is to that direction. So if you have decreased albumin, the water is going to flow to the extravascular space. Okay? All right. Reasons for increased interstitial fluid. We list 5 here. Let's take each one separately. Increased osmotic pressure of the interstitial fluid. An increase, I'm not going to read this to you, you can see it here. The increase in total body sodium is going to pull fluid out of the vascular space into the extravascular space, resulting in generalized edema here. You're going to be puffy all over. Eat that bag of Funyuns tonight and you'll see that. Okay. Decreased oncotic pressure of the plasma protein. I just gave the example of albumin. This is what you see most frequently in malnutrition. Malnutrition can take the form of alcoholism, that you would rather drink your dinner than eat your dinner. If you're concerned about malnutrition, what you want to measure in the blood is that you want to get a serum albumin level. And by the way, there's also a thing that circulates in your blood. It's called prealbumin. Prealbumin also, obviously, it's synthesized in the liver. Prealbumin contains more essential amino acids than does albumin. You only get essential amino acids by what you eat. You can't make essential amino acids. So if you really want to get an accurate measure of nutritional status, get a prealbumin. If there's a reason, like if you're peeing out albumin because of kidney disease, glomerulopathy there, excessive albumin loss, if you're peeing it out, if you're losing protein in the urine, you can just get an albumin. If you're interested in dietary intake of protein, get a prealbumin. Increased venous hydrostatic pressure of the intravascular fluid. Yes, ma'am.
Sorry, real fast. What does oncotic mean? The number 2, it says D. Does
Oncotic pressure, if we go back way in the beginning, no, it's not. Osmotic pressure. Oncotic pressure is consider it the osmolality. The third one to do with essentially backup of fluid. And note that the primary backup is on the venous end of the circulation, not the arterial side. So if you're looking at venous stasis, which is a condition where the blood flow through the veins is not sufficient enough, and it backs up. You see venous stasis a lot in congestive heart failure. Venous stasis produces changes in the skin. The skin becomes darkened. It loses its hair. It becomes orange peel-like. Those are all signs of essentially venous pooling. You see it a lot in diabetics, you see it a whole lot in people with congestive failure. So especially in guys, when you're assessing the lower extremities, looking at peripheral vasculature, I'm going to feel your pulses in your feet. And I'm going to look at your legs to make sure that there's a normal hair pattern and that the skin is not tight and rigid. That's part of a physical exam that you'll get into. Okay. The next one is obstruction of lymphatic drainage. We touched on this in anatomy. If you interrupt the lymphatic drainage particularly from a limb, it's going to back, the extracellular fluid is going to back up. The reason it can be blocked, there are a host of reasons. One of them, as we've mentioned, is mastectomy, where you go in and you remove lymph nodes looking for a spread of cancer. The other is if you radiate the breast for breast cancer, which used to be a big thing, I guess it still is, you can scar down the lymphatic channels. Parasitic disease, the most classical one would be elephantiasis. Elephantiasis, which is a subtropical African disorder caused by the parasite. Anybody know what it's caused by? For bonus question, for bonus points. Too late. Wucheria bancrofti. You should know that. Everybody should know that. Wucheria causes elephantiasis. Produces lymphedema because the bug gets into lymph channels and blocks it. And there are a whole bunch of different types of wormy diseases that can cause lymphedema. And finally, removal of the lymphatic structures itself. And finally, increased endothelial permeability happens during the inflammatory process we talked about last week. Poison ivy, bee stings, contact dermatitis, allergic conditions of the skin that will cause leakage of the fluid out of the vessels and edema. Okay? Go pee potty and then we'll come back.